have with us Dr. Basab Mukerjee, sir. Sir is here to speak to us about a novel and exciting molecule, which is iron isomaltoside, which is going to revolutionize parenteral iron therapy. For his formal introduction, Ganesh, can we have the CV on screen, please? I would request our chairperson, Dr. Sudesh Doshi, to please do the honor.
Yes. Well, it's an honor to introduce Dr. Basab Mukerjee. As we know, he has done his medical schooling from CMC Vellore. He is not only at local level, but also FIGO level. He was FIGO coordinator of South Asia of Safe Abortion Community, clinical examiner for RCOG examinations in India, member of Governing Council ICOG for 5 years, honorary secretary of Bengal Obstetric and Gynec Society, Young Gynecologist Award of AOFOG 2011 at Taipei, past chair Family Welfare Committee of FOXY, Vice President Election FOXY 21-22, and organizing secretary of AICOG 222. We had a wonderful conference at Kolkata. Thank you, Dr. Basab, for that. And the dais is yours. Dr. Basab Mukerjee, please.
Thank you, Dr. Doshi. Thank you very much. It's a pleasure being here. If you have friends like Dr. Pratik Tambe, you will be getting invited to AMOG's sessions multiple times. So thank you, Pratik, for inviting me yet once more. And it's just an absolute pleasure being here. Meg, Madam, Namaskar. It's always so happy to see you and seek your blessings. And we are all with you in your endeavor as it keeps on coming closer. So over the next, I'll just share my screen. Yeah, so I think just a few thoughts before I take it forward. One is the thought which I always we discuss whenever we talk about anemia. The NFHS is one of the most renowned government documents where we have an incidence of things happening in our country. And the NFHS 5 keeps on showing that anemia is still a really major problem in our country. And if you look at the community programs which the government has spent crores and crores on over the last 6 decades on anemia, we still find ourselves short that we still haven't been able to conquer the disease. Though the maternal mortality, of course, has come down, but the anemia as a disease or anemia as a prevalence remains more or less same. But I like the way Dr. Rekha said that when you breaking up the states and you're taking a few of them who've done better than the other ones, then what have they done differently is something which is really worth looking at. And what seems now is a multi-pronged approach. As Dr. Sudesh Doshi said, you have the albendazole, you have the fortification, you have the oral iron, you follow it up, you keep on checking it, do your antenatal visits. And I think it's a multi-pronged approach that works best, and there's no magic difference that something can do. But sometimes we usually wonder, I think, whether diet has a lot of things to do in India because of a carbohydrate-rich diet and a phytate-rich diet and the tannins, whether that has a role in interfering with iron absorption is something which possibly can be a thing of research. Also, the Indian GI tract, whether that's a little different in absorbing iron than the other GI tract, is something I think is worth looking at. So one of the different methods of coming out of anemia or conquering it or trying to beat it, besides the Anemia Mukt Bharat, which has been a massive program by the government, which we are all supporting at FOXY and looking forward to how the change is happening at the ground, is the role of parental iron. So parental iron has been in the vogue for at least 10 to 12 years. We have had talks on parental iron at different forums. It all started with iron sucrose and then FCM, and now this new molecule which is there, which I think we will have some more discussion over the next 15 to 20 minutes. So parental iron is when there is a poor tolerance to oral iron therapy. And what we keep on reiterating at every discussion is that you have to start with deworming, and you have to start with an iron-rich diet before you go on to oral iron, and only after that does parental iron come into the picture. Though there are some of our luminaries in FOXY who do recommend that in 3 trimesters, you give 1 shot of parental iron in each of the trimesters, and that will cover it. You don't have to rely on her to have oral iron, but still, I think we do understand that iron-rich diet and oral iron therapy does remain the rock solid first line of treatment. And after this would be parental iron, but that would not be a replacement at any time soon to oral iron. So whether it's poor absorption, whether it's non-compliance, whether it's poor tolerance, there are several issues of oral iron, where parental iron come into the picture, and there is a definite role where you have to see where you can give it or how it can be administered. So whenever there's a new parental iron in the market, that would stimulate interest, because recently we have heard about anaphylactic reactions happening with parental iron. Of course, it's much less than what used to happen in the iron dextran days, but at the same time, whenever you're giving an iron preparation, you have some anaphylaxis of varying degree, sometimes mortality, but often morbidity. It is something which is unwanted, and you would like to, of course, avoid that. A few points or tips there is oral iron should be stopped at least 24 hours prior to therapy to avoid a toxic reaction, and you would restart 1 week after the completion of the full treatment of parental iron, not usually before that. So first of all, a prerequisite of parental iron is, of course, confirm the diagnosis of iron deficiency anemia. As Dr. Rekha very nicely in her presentation said, that anemia can be of different types, and only if it's iron deficiency, which of course is the commonest, then you need to give iron supplementation. So whether it's diet, whether it's oral, whether it's parental, you have to give if it's an IDA or iron deficiency anemia. And then, of course, if there is because a parental iron is still emerging, and you have to have some sort of a management of anaphylaxis ready, though it's very rare, less than 1 in 1,000, possibly even less. But at the same time, you need to keep things in mind. Sensitivity test prior to infusion recommended, not done. We'll talk a little bit more about that as we go forward with this presentation. And contraindications, of course, if there is a history of prior anaphylaxis, first trimester of pregnancy, we try to avoid most of the things. Chronic liver disease, active infection, then of course you would like to avoid it. So calculation of the dose of parental iron, well, this is especially if you're giving the full dose together. A lot of us like to give it in parts, but it's good always to know what is the deficit, so that you know how much you really need to cover if you're covering it. Because when you're giving parental iron, in most cases, you're giving it instead of oral iron, and you would try to cover as much as possible in one shot, if possible 2 shots, and then to know how it is. So 2.4 into the target hemoglobin, you put it as 14, 15 minus the actual hemoglobin into the pre-pregnancy weight with 1,000 mg addition for replenishment of stores. So the story of parental iron, as most of us would have heard, or most of it was more than 20 to 25 years. I think from the time that I was in undergraduate days, 30 years ago, we did hear about iron dextran. And then as we passed out, iron sucrose came into vogue early 2000, and middle of 2000 to 2010, that was iron sucrose, which was a time. And then slowly FCM took over the market last 7 to 8 years, possibly. And now it's Isomaltoside, which is the new iron molecule, which we will be talking about today and how it's different. So parental iron, the classification depends on the type of complexes. 1, 2, 3 thermodynamic properties are here, and examples are there. We'll come to more details later. The intramuscular preparations are no longer used. So you can talk about historically. So this is how it was there when it used to be there. It was a painful injection. There was discoloration of the skin, chances of abscess formation, and that's why it's gone out of vogue, and now it is almost never used. So what we're talking about is only IV iron usually. Mild to moderate iron, how much do you want to give? So this is just a comparison of the number of doses that you need to give if you're giving the different salts of iron as a parent in the parental form. So if you're giving iron sucrose, because of the limitation of the total number of doses which you can give, you have to give it in 7 to 9 doses for a mild to moderate, and even more than 10 for a severe deficiency. If it's FCM, of course, you can reduce the number of doses, and with the new iron Isomaltoside, you can even lower it further. So the basic idea is getting maximum through minimum. So one visit or one OPD visit would possibly take care of most of the deficiency. If you calculate it well, give it well, and that can be done. So iron, so how does IV iron, what is the composition? It may be a good idea to go a little bit through that. So just giving the very nice diagram on the left side of the screen, where you see iron 3 oxyhydroxide oxide core. So that's where the iron element is. And there is a carbohydrate shell outside, which will take it past the gastric acid and the GI tract, directed towards the reticuloendothelial system, where the actual breakup will happen. So every parental iron is complex with the carbohydrate moiety, which holds on to the iron till it reaches the liver and spleen, and there it is going to be released. And if the iron is released earlier, then there will be labile irons, which are not very good. So what are labile irons? How are they harmful? They are free irons released from the complex after administration. So it's broken down before it actually reaches the reticuloendothelial system. And these free irons are responsible for a lot of the side effects of parental iron, namely hypotension, hypersensitivity, oxidative stress, cytotoxicity. And so we would like to have a product which would have the least amount of labile iron, and isomaltoside seems to be one of that, which is the new kid on the block. So how has it low iron potential? Because it is a strongly tightly fixed structure. The matrix is very tight, and that is the reason why it doesn't break up so early. It breaks up only where it's supposed to. So controlled and slow release of iron, and this is tries to avoid the potential toxicity of labile iron. So labile iron is something which we never heard much of, but with the parental iron in picture and with the new product in picture, you can understand, seeing at a graphical representation of the bar diagrams, that the new salt iron-3 isomaltoside has less amount of labile iron in this study published in the American Journal of Hematology compared to ferric carboxymaltose, which most of us are now using now, and iron sucrose, which most of us used at one point of time. Also, we're using now, possibly sometimes for cost, sometimes for thing, but it's much more than a carboxymaltose. So here is the maximum single dose. Again, as you said, see, you can give more with less. So iron isomaltoside, you can give a large amount with a less amount of dose, and you're covering more than you're covering with sucrose, of course, and also compared to FCM. So it's the only IV iron with no upper limit of IV iron administration dose. There is an upper limit, we'll come to it later, but generally it's much more liberal than the FCM before. And it is a third generation IV iron compound, which showed it to you before. And there are approvals which have already been received in Europe, in DGCCI in 2013, nearly 10 years ago. And now it's just come up now, and US FDA in Jan 2020. So it's reasonably well researched, well studied, and has been given the nod by all the nod agencies, which you need to have a nod before you come into the market and you establish yourself as a good brand. So parental iron isomaltoside, it's absorbed by the reticuloendothelial system cells, as we said, the liver and the spleen, where it's split up and the iron binds to the protein, forms ferritin, replenishes iron store, and that is how it exactly works. So some of the clinical evidence which has come out from here. So the first set of evidence is a comparison with iron sucrose, which in my opinion should not actually be there, because you should be actually comparing it directly with iron FCM, which is there in the subsequent set of slides. So the initial slides as iron isomaltoside versus iron sucrose. And here there's a set of 1,500 plus patients with IDA who had GI and gynecological blood loss. And here the number of visits, of course, you had less visits with isomaltoside, and had a hemoglobin rise of 2 gram per cent. So that is one thing which was noted here. And the single infusion, again, continuing with the same study, about the hemoglobin rise was slightly higher in isomaltoside after 2 weeks compared to iron sucrose. And proportion of women also, there was a significantly higher rise of women who had increased more than 2 grams. That was quite fast at 2 weeks a time. Then again, a study from American Journal of Hematology, and this is a randomized trial with, again, isomaltoside and iron sucrose. Here, the number of patients, again, with this also is showing the number of patients with a faster rise in hemoglobin at a shorter duration of time is with the newer salt than the older salt. And it all happens in 26 days is what here we have seen here. So superiority in comparison with iron sucrose, I think we've already mentioned this. We don't need to repeat this. It has less labile iron, does not require a test dose. Iron sucrose also, I don't remember us giving test doses, but we used to give the initial part slowly and then fast. So iron isomaltoside versus FCM, well, this is where the crux lies. Like you always need to compare with the golden standard or whatever the most commonly used molecule of that time. So once you want to make a competition, or once you want to establish yourself as a superior salt, or possibly more reliable salt, you would need to compare with the one which is most commonly used now. So drug safety, this is a new concept of hypophosphatemia, and this is has a higher risk with FCM. And this is, so we're just trying to get through the physiology here. There's something called fibroblast growth factors, or FGF. And this is already there in iron deficiency, and also it increases in ferric carboxymaltose. So what does FGF do, and how does it cause hypophosphatemia? Well, it leads to reduced phosphorus levels, vitamin D, calcium absorption. It works mainly at the kidney, at the renal level. So here it's where how it works. It inhibits the reabsorption of phosphate in the renal proximal tubules. And as that is done, more phosphate goes away from your body through the urine. So that's hypophosphatemia. How does it work clinically? Well, clinically, you can have generalized weakness, fatigue, respiratory depression, just symptoms of anemia again coming back even after giving an IV iron injection. So how much is it clinically relevant? How much do we see it in practice is something which we really have to look at it. But hypophosphatemia is definitely studied as one of the risks of FCM, which is more than the risks associated with the newer salt. So drug safety, phosphatemia, here there is studies where they have, this is published in the JAMA 2020, significantly more pronounced drop in plasma phosphate from baseline in patients receiving FCM than iron 3 isomaltoside. But again, how much is that clinically relevant is something also very important. It's not just the biochemical factors that we need to consider. And here you see that the phosphatemia is compared to the isomaltoside is quite high in FCM in both these trials, which have been done, published in JAMA with 245 patients. No changes in vitamin D and calcium hemostasis with isomaltoside. Severe hypersensitivity reactions, 0.8% in iron isomaltoside, 1.7% in FCM. It could happen to anybody. Again, you need to get prepared for things like this. Most of the times it is transient, but again, sometimes it may be serious, which needs medical attention. So FCM induced changes in vitamin D, calcium hemostasis that triggered secondary hyperparathyroidism, likely to contribute to the persistence of hypophosphatemia. It may go on beyond the duration of your administration, or beyond it's last longer. Isomaltoside versus FCM, indirect treatment comparison, cost and effectiveness. Well, here, as you have to give possibly more than one infusion, your cost will generally be more than if you want to give one. And here it is a comparison, and they have so calculated cost per responder and number needed to treat to avoid a single infusion. And this is again what they come up with, 910 for FCM and 580 for iron. I think this was in UK, so I think it's in pounds in the GBP. And that's the difference there. So conclusions that they made from this cost-effective study is that the iron 3 isomaltoside, other than FCM with patients with IDA, was dominant and would reduce the number of iron infusions required to correct iron deficiency, reducing the cost associated with IDA treatment and simultaneously increasing proportion of women with IDA experiencing clinically meaningful hematology response. Now, it's quite ironic that for an anemia study, we need to look at United Kingdom for comparison of these two salts, where we have so much of anemia in our own country. I think it's time that the company keeps on giving a few samples for theses of postgraduates in our country, so that we can generate some data of our own, which I think would be much more accepted and much more ideal in our setting, and see how exactly it features. So how iron 3 isomaltoside is superior to ferric carboxymaltose? Well, here it is. It's less labile iron, as we said. This is a new concept of labile iron, which is the free iron, which has come out from that carbohydrate shell, which you had seen in this initial part. So that is more in ferric carboxymaltose than the newer one, isomaltoside. So that is something which is a plus point there. Iron deficiency correction in a single visit. Most of the time, FCM also can be done in a single visit. Sometimes you may need more than one, but generally that is how it is. There was one point of time where a lot of reactions were happening because of the infusion, which we were given slowly, but now we understand that it has to be over in 15 to 20 minutes for the best results, and you're having a less chance of complications. So various segments it's been studied. Chronic kidney disease, of course, ONG, and onco-cardio, inflammatory bowel, and things. During pregnancy, what are the studies? That's a very important aspect. And here it's a category B drug. Whether we have studies and surveys, I'm not sure, but it's category B, so it should be all right. There's 21 prospective trials using 8,000 patients for iron 3 isomaltoside, FCM, and retreat for hypersensitivity. It was lower in the new salt compared to the older salts. And of course, that's the reason why you've got the FDA approval. That's the reason why you've got the DGCA approval and all the approvals required. So 213 pregnant women beginning of the second trimester, and until a few days delivery, so it was a range, and they all got a single dose of iron 3 isomaltoside. This is published quite early, 2017, and it was safe, which I think is safety, convenience, efficacy, and negligible adverse reactions. Postpartum, of course, this is a very important part of the pregnancy period, and I think all of us do we speak about postpartum anemia and the postpartum care in general, and I think it's so important that after a delivery, whether a normal or a section, you have to have the hemoglobin checked, and you have to do some correction before the woman leaves the hospital. So that is so when we talk about contraception, that's one way, and we also need to talk about anemia, because you have an option there where you can intervene, and if a person is non-compliant or poorly compliant, you have an option which you can give her of just continuing the IV drip with a parental iron, if that is what she wants and if that is helpful in her, because she needs to have a fair amount of hemoglobin when she's breastfeeding, because you need to understand that also affects the baby, the breast milk iron content there, and there are several issues on that regard. So here there is a postpartum period fatigue, and here you have here there's a study on oral isomaltoside versus oral. So oral, as I said at the beginning, is always the gold standard. That is what will come first, but there are people, a sizable number we see in our population, who either are intolerant or are poor compliance, and or have definite side effects with oral iron, where they want alternatives. It may come at a price, but some people are often, a lot of women who are willing to pay that price and to have a benefit, which if you can extend to them, may have a very positive effect on them. So single dose isomaltoside in a postpartum period also. So we spoke about antepartum after the first trimester, and also postpartum has helped in having an effect. So 200 women with postpartum hemorrhage, single dose IV infusion. If you're doing it instead of blood, that will be good. If you're doing it with blood also, okay, but as long as it does its thing. Again, as I said, 2 times higher iron in maternal milk. So I think that's also an important thing. Once you diagnose a person with postpartum anemia, you need to really correct the anemia early, because she has to, because it's important that the iron content in the breast milk also is not affected. So the first 6 weeks, if you take for it to wait to increase, you may lose on time. And so it's important that we correct it early after a delivery setting. So here, a single dose IV iron versus red blood cell transfusion for severe postpartum anemia. And this IV iron could be an alternative to red blood transfusion. Yes, that is one thing. Again, you can give those options also, because blood transfusion has its own effects. So this is a dose calculation. I think we'll skip that. And this we have already discussed. And here, I think this we'll skip, and we'll go directly to, oh, sorry, I'm going backwards. So IV an infusion of iron isomaltoside up to 20 mg of iron per kg body weight, or as weekly infusions. and then you can split it into 2 parts, and you infuse undiluted, very much like FCM. You can give a slow IV shoot as long as you know it's in the vein, or you can dilute in sodium chloride. That's give it over 15 to 20 minutes and make sure that it goes in fast, and you have a very nice IV line out there. And so that's the idea. Blood transfusion, yes, that's one option, of course, and that is an option when you don't have time and the patient is already coming with a congestive heart failure and with low hemoglobin. Of course, there is no alternative to blood and blood products. Same thing if she's in acute PPH or some severe bleeding, you need to settle it, of course, with blood and blood products. You don't have a chance of giving parental iron at that point of view. Risks of blood transfusion, we all know, and that is something which you like to avoid, and that's the reason why for any chronic setting, I think we have an option of parental iron. So just summarizing the discussion we've had here, friends, IV iron use in women of reproductive age has increased rapidly. And a lot of our gynecologist friends, a lot of people who have tuned in here are responsible for that, because we in our clinical practice have understood that this is an option which we have to give to our women, and we have to use it in certain cases for the best interest of the women. And also any new salt which comes in this regard stimulates and triggers of interest. So iron 3 isomaltoside is a new IV iron which can be given as 1000 mg and above in a single visit. It has faster, more predictable arise compared to iron sucrose, of course. In some instances, comparable to FCM. In some instances, slightly more than FCM. The no test dose required, which we don't give in FCM either. Possibility of a full iron repletion in a single infusion, which is often done, and acute anaphylactic reactions or delayed allergic reactions are not very much seen in clinical observation trials, but we need to be ready for everything. So it's a safe, effective, and convenient approach which we can give an option to our patients as something new and something more effective as it stands now. So low immunogenic potential, low potential, no test dose, category B in pregnancy, as we see. And then overall less treatment cost if you take everything together, if she doesn't have to come twice, and predictable hemoglobin rise. Thank you very much. It's been a pleasure.
Dr. Sudesh Doshi, sir,
Yeah. Thank you, Dr. Basab, for that exhaustive knowledge of our newer IV iron. Iron has always been there in the market since 1960s. We are always trying to improvise. The government also has accepted the changes. Previously, when we were college days, we used to know that government only used to do ferrous sulfate. But now the government also make iron sucrose available, and it's very much available in all PHCs. It is improving anemia. The newer iron definitely is a good prospect. We will have to try it out. We will have to look at it, because every time a new product comes into market, it is always like what we say in Marathi, "Akudshingi bahududi gai ahe," asं सांगितलं जातं. And then the newer one comes again in the market. Yes, definitely it is a good thing. We will have to try it in the market on the patients. And as our experience goes on, we find it fruitful, we will use it. Also, over the time, the price factor will also come down. As we know, the newer products are always costly. So as soon as it becomes affordable and we all use it, it would be definitely a new armamentarium in our basket to use against anemia. Thank you, Dr. Basab, for it.
Thank you.
Thank you, Dr. Sudesh Doshi, sir, for your expert comments. I have just one small slide to share, and with your permission, I'll just share my screen.
Yes, sir.
Dr. Basab Mukerjee was saying that it's difficult to get Indian data for most clinical scenarios these days.
Yes, the irony, it's the irony in an iron situation when you get data from UK for
anemia in UK, when we have like tons of patients here in India.
Yeah.
This is one slide which I have regarding the recent Indian experience. I think this is updated up to January of 2023. 49 clinicians have used this particular molecule I3. Nearly 400 patients, and the rise in hemoglobin is substantially good, and it's shown very good efficacy with zero anaphylaxis in this small series of about 400 patients. So I think that's something which is significant. That being said, we need to have more data, we need to have larger volume, plus we also need to have multicentric data. And for anybody who's logged in, I think we have nearly 800 viewers who are logged in live today to listen to a program on anemia in the afternoon, which is something, unimaginable. 800 people still, even in 2023, want to learn about anemia. So
Yes.
if any of you wants to conduct a clinical trial, you're most welcome to get in touch with us or our academic partners, Glisten, who are the makers of injection I3. I'm pretty sure they will be able to come to some sort of understanding and help you out as far as the costs are concerned and helping you out regarding the conduct of the clinical trial is concerned. We welcome more and more people to use this new molecule because unless it is used in our Indian patients, we will not know what is the efficacy. We will not understand what are the issues, the practical problems that all of us will face in clinical practice. So thank you very much. I see Dr. Rekha is back. Her video was off for a while. And we have 2 or 3 questions which are coming from the audience. So we'll just take those for the Q&A session. The first is from Krishnagiri, Dr. Rekha. So I'm pretty sure that is for you. And the question is asking, this is from Dr. Venkatalakshmi. What is the role of parental iron as far as antenatal anemia is concerned? I think it's been answered already by Dr. Basab, but since it's from your own society, I thought you might want to take it. Can you please unmute, ma'am?
When the patient, like when Basab sir told, if the patient is non-compliant or if they have other GI side effects, parental iron is the drug of choice. And now with I3 coming in, I think most of us are using FCM, but I3 also can be an alternative. And I think all of us should get in with the clinical trial and use more of I3 if there are less side effects. Yeah.
Thank you. There's another question from Dr. Surabhi Ramaswamy. She's from Dharmapuri, and she's asking, is there an easy HB estimation home kit which is available? Now, this is another practical issue probably for primary health centers and for the interiors where access is poor. There, where they want to quickly triage a patient, whether this patient needs parental iron, this patient needs admission. That's probably
There's a new digital hemoglobinometer, which some of the companies are promoting. But how much is it, or how can the patients procure it, is a big question. It's still cheaper to do it in our labs. Just if you're going to do only hemoglobin or CBC, it's not going to cost more than 200 rupees in our setup, where we are all in the periphery. So 200, 250 will be the cost. I think they can afford that CBC.
Thank you. This is a question from Dr. Zoya Khan in Jabalpur, and she's asking, what are the causes of anemia in teenagers these days? I think this is something which you will hit out of the park for a 6. Basab, any comments?
Anemia in teenagers? Well, that's very interesting because we talk about malnutrition of a different type also. So the malnutrition we used to talk about, generally you think about Africa, you think about a rural area, you think about people who are thin, people who are malnourished, but there's another malnourishment of the other sort where you are not having the nutrients which you need to have, you're not having the food which you need to have. The fruits and vegetables are missing from the diet, and it's all filled with carbohydrates and things which your tongue invites you, and not your heart, not your heart and your brain. So I think so there are a lot of dietary problems in adolescents which are one of the causes of anemia. They hardly have their health checkups done. That's one of the things. About worm infestations and malaria, the incidence is more or less same in adolescents and adults. I don't think that's a difference. But I think food is definitely something which we all can get educated in, food which is iron rich, because dietary wise, I think most of our gynecologists are quite poor, especially in an urban setting. In a rural setting, they must still give some good quality advice. But personally speaking for myself, I think we are not very well dietary trained to give a very basic advice about iron rich diet and things about that. I think those are things which are very important that we need to get ourselves clear with. Dr. Rekha, if you want to take that adolescent anemia, what you think?
In these children, recently we've seen a lot of obesity, then the type of lifestyle and food. Hypothyroidism is on the rise, and the anemia due to hypothyroidism is also one of the causes. And in case of these patients who are either PCO, the inflammatory process also has a decrease in hemoglobin levels. So I had mentioned in one of my slides, the inflammatory causes of anemia also is there in the alternative reasons for anemia. So I think mainly lifestyle changes, dietary improvement, and then substantial supplementation of iron deworming, and regular counseling and coordinating with the patient and the family. Mainly the parents need to be educated in these cases, where they need to understand that they don't go by the children's tantrums and give them a proper balanced nutrition. And as part of our clinical work, I think we should counsel them regarding the diet rather than sending them to a dietitian, because they wouldn't take the dietitian so seriously. So we need to create an impact on them, saying that diet and management in diet is the first choice for these children.
Thank you, ma'am. Thank you very much, Basab. I think you mentioned it that the Indian carbohydrate-rich diet with lack of protein, excess of phytates and other minerals which inhibit iron absorption is also a very important positive factor which we neglect to talk about. The next question is from
Dr. Doshi wanted to make a point. Pratik, Dr. Doshi wanted to make a point. Yes, Dr.
Yes, sir.
Yes, sir. About food fats and everything, sometimes as we see, the junk food contains less of iron. But one Indian food which we all love is good or shengaka laddu, that is groundnut and jaggery laddus. They do have a cultural value. They definitely jaggery give the highest amount of iron. So this can be incorporated in their style, either as a chikki, either as a vadi, or a good shengaka laddu. And that will help in iron, because food fats, I know, difficult to break it. But Shenganika laddu is a favorite of all, and everyone can have it, a good protein and iron diet.
Thank you, sir. Thank you very much. The next question is from Dr. Jitendra Kumar Nath from Morigaon in Guwahati. And sir is asking, in case of congestive cardiac failure with severe anemia, probably this patient is admitted, what is the correct approach to correct the failure? Do you give transfusion? Do you give parenteral iron? What exactly would be your approach? I think, Basab, this is right for you.
Yeah, so I think transfusion does work best or fastest, of course. But again, as you know about congestive cardiac failure, the little medical knowledge that we all had during MBBS and MD is that you need you're afraid of a fluid overload. So obviously you'll be giving the whole blood is gone nowadays. So packed PRBCs is what you will be using. Of course, you'll be using possibly diuretics along with that. So you flush out the fluid out of it and get the most concentrated RBCs in the system. So that would be an immediate effect. But again, if it's along with other things, you may give oral or parental iron as a top up, but your immediate priority would generally be PRBCs to correct the anemia immediately and to have the relief of symptoms. It depends on what setting you are doing. If it's an admitted patient, a hospitalized patient, of course, it's much more easier to do that. If it's not a patient who's admitted with a CCC, I think they should need an admission and then to be tackled this way. But blood products, of course, would be the thing of choice. And here, the oral and parental are mainly for a chronic setting and not for an acute setting.
I think another key point is that probably you don't do a complete correction with blood products, packed RBCs as well, for fear of overload. Maybe you correct up to 7 or 8 grams and then the rest you give a top up with parenteral, and that would probably be the way to go for an admitted patient. Of course, everything depends on how much time you have until she goes into labor. Sometimes the act of just giving transfusions, I remember in the good old days, patients who go into labor 24 hours later after you had given the blood transfusion. That's something which is unpredictable and something which is not within our control as well. One last question we have, this is from Dr. Vijay Kumar from Daudnagar. And I think, Basab, this is for you. When platelets and RBC are down along with HB, then what would be the management? I think he's talking about pancytopenia.
Yeah. So I think, so if platelets are down again with, so again, you have to look at the counts. So a pancytopenia, typically we know from our medicine days, there are 3 wings. So one is the RBC wing, one is the WBC, and one is the platelet wing. So putting it simply, if all of them is down, then you think of some bone marrow suppression or things in those lines. Obviously, at some point of time, a hematologist will be in the picture. You will not be able to tackle it together because we have limited expertise in this field. So either a medicine doctor or a person of a hematology background or a hematologist would generally be brought into the picture, or would be referred, the patient be referred to somebody like that. But till then, if you want to have a correction, Again, depends on the setting in which you have them. If it's an outdoor setting, of course, you'll start with oral hematinics and try to build it up, give a protein supplement along with that, because that's something which is very good for a boost, which often we don't do. It's not just to limit up oral iron and deworming. You need to give a protein powder also along with that. That gives a good boost. So those are the things which you'll do. Possibly you repeat the values to make sure that it's right. You need to repeat it from another lab, possibly a more reliable lab, your NABH accredited lab, let's say. And then those are the things you'll do. And you will also do possibly other parameters which we know are, like the serum ferritin, the peripheral blood smear, to have the CBC, again, a complete view of the MCV and MCHC. As Dr. Rekha very nicely pointed out, there's different ways of which you can find out what you have before you're sending her off there. So those are things. Also the drug history, what medical drugs she's on, because that's one of the reasons of bone marrow suppression, a lot of other things to keep in track. A nice peripheral smear to see whether there's anything to be seen there. These are some basic things back to old days of medicine, which should have some idea or some direction. Either if she doesn't have a hematologist anywhere near, she doesn't have a medicine doctor, she's heavily relying on you, or there'll be time for when she reaches there. So these are some basic things I think from my end I would like to do before, I think. Dr. Rekha, you'd like to come in? Is there anything else you need to add?
Ma'am, you're muted. Please unmute.
In this patient where the platelet is also low, I think we need to also rule out other infections before starting on any other evaluation. Because if it is a viral infection or something, if they have had a recent viral infection, this picture can be there. So probably we'll give them another week or 10 days time and reevaluate and then take it forward.
Thank you, ma'am. And there is a sub question to this question. If the HB, RBC and platelets are down, but the TLC is high, patient has excessive weakness, what could be the issues? I think we would be looking then at something like leukemia or a lymphoma, AML, CLL. If my memory serves me right, my undergraduate hematology.
Again, Pratik, like we're not really skilled or trained to talk about that. I think like at some point, it's quite early in the days, he would have been referred to a medicine or a hematologist. So let's not talk.
Advise about look at the details. So I think that's the end of the questions. We've had a fantastic engaging session today. We have nearly 900 viewers live. Thank you so much to both our respected speakers and our chairpersons. Any closing remarks before I propose the official formal vote of thanks, please? Dr. Rekha, Dr. Sudesh, Dr. Basab, anything?
So preventing anemia even among doctors and our educated and literate people is still a Herculean task. Sir. I think we as doctors first need to take care of ourselves and people around us.
Don't listen to other doctors, ma'am. That is the problem.
Yeah. So, no, I'm seeing a lot of our younger doctors who are coming to us. They're post-MBBS, PG students. They're also very severely anemic. I think it's our fraternity that needs to be looked after first before, implementing it in the society and other people. So as a team, we need to work. Yeah, we need to self-care as a point of care first and then take it forward.
Yeah,
this is something I want to tell.
Yeah, the recent craze generally has been vitamin D3. So vitamin D, a lot of people are doing, and like that's a craze recently. But anemia has gone to the back burners. We're not talking about hemoglobin or CBC anymore. So I think you just add a CBC to the vitamin D3. I think that would make it perfect, where you can just find out both, because vitamin D is a fad now. Vitamin D3, everyone's doing vitamin D, and you just love to pop in a tablet once a month or once in a week, and that's thing. But I think you're right, Dr. Rekha. We are hardly checking our hemoglobin for people who need to do it. So,
and the other thing is about diet, sir. A lot of our food around our house, like in the rural area, we have this moringa leaves available and greens available very easily. Just that they can take that regularly every day, weekly, 2 times or 3 times. That itself, their diet, proportionally, the diet should change. I think the diet implementation is something all of us have to emphasize.
And also in a vegetarian setting, a veg setting, it's really really just a scramble for your iron in the food. In a non-veg, at least you're getting it default, but in a veg setting, you have to really scramble because
and the new fad about being vegan also is getting
being vegan is like, again, that's a fashion. Being vegan.
It's not social media to talk about these things anymore.
Some other time, some other time.
Yeah. Okay.
Thank you very much to both our esteemed
Thank you. Thank you.
Thank you very
Pratik
much,
sir, for giving
Pratik.
us this opportunity.
It's
Thank
a
you.
pleasure.
Thank you,
Absolute
Amox.
pleasure. Thank you.
So I'll just propose the formal vote of thanks at the end on behalf of the AMOG's Endocrinology Committee. This is Dr. Pratik Kambe. I'd like to express my gratitude to the AMOG's office bearers, our President, Dr. Rajendra Singh Pardeshi, sir, Secretary, Dr. Sujata Dalvi, the ICOG office bearers, our Chairperson, Dr. Lakshmi Shikhande, and Dr. Ashok Kumar, our Secretary. Thank you for the ICOG credit point. Two excellent chairpersons, Dr. Sudesh Doshi, who is our Zonal Coordinator of AMOGS, Dr. Sarita Bhaleta, who is a Governing Council member of ICOG. We had Dr. Mandakini Meg, a past chairperson of ICOG and candidate for President Foxy, who came in for quite some time, gave us a lot of her expert comments. Two excellent speakers, Dr. Rekha Rajesh, President of the Hosur and Krishnagiri Societies. Thank you so much for being here and speaking on Anemia Bharat and Oral Iron. And of course, our star speaker for today, Dr. Basab Mukerjee, past Vice President of Foxy, for talking about parenteral I3 and how it's going to be a game changer as far as treatment of anemia is concerned. Thank you everybody who's logged in today. We have nearly 900 viewers across the country. And of course, I must place on record my gratitude to Science Integra, Subbu, Ganesh, and everybody in the backend team who does a lot of hard work for all this experience series with the AMOG's Endocrinology Committee. Last but not least, I need to also place on record my gratitude to Glisten Pharma, the academic partners, makers of Carbesil, Alimag, and Injection I3, for being our academic partners for the past 3 months and bringing a lot of important take-home messages to the audience throughout the length and breadth of this country. Thank you again for logging in. We hope to see you soon at the next event. Until then, goodbye, God bless, and take care. Thank you very much.
Thank you, sir.